It's my pleasure to present the randomized phase 3 results. The first, KRAS G12C inhibitor, Sotorasib versus docetaxel for previously treated patients with non-small cell lung cancer harboring KRAS G12C mutations. Here are my disclosures. So we'll jump right in this morning with the study design. Patients enrolled in CodeBreaK 200 had newly diagnosed metastatic non-small cell lung cancer. They had received prior platinum and immunotherapy. They had no brain metastasis, although a history of brain metastasis was allowed and was a stratification factor. Patients were randomized to Sotorasib. It's an orally administered KRAS G12C inhibitor versus docetaxel. I should say that KRAS mutations happen in about 30% of lung cancer, and these KRAS G12C mutations happen in about 13% of lung cancer. This trial was enrolled over 11 months. The primary endpoint was PFS by blinded independent central review. Secondary endpoints, efficacy, tolerability, and patient-reported outcomes. CodeBreaK 200 met its primary endpoint, demonstrating superior progression-free survival over docetaxel with a hazard ratio of 0.66, p-value of 0.002. So said another way, there was a 34% reduction in risk of progression when treated with Sotorasib versus docetaxel. Likewise, there was a near doubling of the 12-month PFS, 10% with docetaxel, and 24.8% with Sotorasib. Sotorasib was well tolerated, and an important secondary endpoint were patient-reported outcomes. This slide shows the time to deterioration, which was more rapid with patients treated with docetaxel, whereas Sotorasib slowed the delay to deterioration in quality of life measures, global health status, and physical functioning, as well as slowed the deterioration of cancer-related symptoms, dyspnea and cough. All of these were statistically significant. There was also a trend towards delay in chest pain with Sotorasib. So, in summary, CodeBreaK 200 met its primary endpoint. It's the first-in-class KRAS G12C inhibitor. It had a significant improvement in PFS versus docetaxel with a 34% reduction in risk of disease progression or death for previously treated KRAS G12C mutated lung cancer. The 12-month PFS rate doubled from 10 to 25%. And of note, the PFS benefit was seen across all subgroups tested, not a slide I showed you this morning. Likewise, secondary endpoints, objective response rate, disease control rate, time to response, and duration of response were all significantly improved in favor of Sotorasib. Secondary endpoint overall survival was not met, but this trial was not powered to look at overall survival, and crossover was allowed. Sotorasib was well tolerated, fewer grade 3 treatment-related adverse events versus docetaxel, and clinically meaningful patient-reported outcomes in favor of Sotorasib. In my opinion, this supports Sotorasib as a new second-line standard for patients with KRAS G12C non-small cell lung cancer. Thank you.
Hi, Neil Osterweil from MD Edge. Question for Dr. Johnson, please. So we've seen the resistance to Sotorasib emerge very quickly. What do you do with these patients for a follow-on if they're lucky enough to survive that long?
Yeah, I think that's a great question and something that CodeBreaK 101, the combination trials, looking at. We look at this as the first step. Probably combination efforts, there are many trials ongoing, adding other drugs to it. Right now, standard of care, there is other chemotherapy, but I would envision in years to follow, there would be drugs added to the Sotorasib. You've seen today that it's well tolerated, and so it will pair nicely with other drugs inhibiting MAP kinase, EGFR, PIK3, even PD-L1.
So I think that it's important addition here that for all the stakeholders, when we discuss about the resistance to KRAS, we compare every time the mind with the other TKI that we use in clinical setting. But this is a very new class of agents with a new activity, new powerful. So I think we need to consider a new class with a new way to understand for the results.